So back to the UK trip in 2008. We were horribly jet lagged. I got the, you always get a cold on the plane. It was a frantic schedule. And, we all had this thing that we were going to just basically write the report and go home and enjoy the trip. Well, we were travelling with the Minister for Health too. He's an interesting character. On this evening of the second day, we all decided to try and escape our minders, if you like, and we went to a pub in the King's Road. And it was in November, and by 5:30 in the afternoon, it was already completely pitch black, and it was very cold and wet. We were sitting around a beer, and Gary Gilhode said, was the head of an emergency department for paediatrics, and now actually is our chief medical officer for Western Australia. Gary was the first person to break the silence and said, I think there's something going on here. There's something about this 4-hour rule. I really like it. I think we have to do it. And I said, Gary, I'm glad you said it first, but I'm convinced we have to do it as well. 48 hours was all it took. And we approached the trip, I admit now, with completely the wrong approach. We thought that we were going to go over there and see a whole bunch of solutions that we were going to cherry pick and steal. But in fact, what we learnt was that if you want to change anything, doing things incrementally or cherry picking solutions is not the answer. But what we heard people say in their own words, in individual sites and individual clinicians, what we heard over and over again was an articulation of this basically a three-pronged approach. Was that if you want to make a fundamental change, you do need strong, consistent political and executive commitment, but you also have to accompany that with better performance management and governance. We also learnt that you mustn't aim for mediocrity. Don't do what the Canadians had done, where they had in British Columbia a 12-hour rule. And they actually said, we sent some people over there to have a look at the 12-hour rule, and the Canadian emergency physicians just basically took our members aside and said, I didn't go, but said, look, we're brilliant. We've got these bulldog nurses who run around and scream at people, and we get everybody out in 11 hours and 59 minutes. But be careful what you aim for, because you'll get it eventually if you work hard enough at it. And we aim for mediocrity, and we hit it bullseye. Again, we were convinced of the elegance of the 4-hour rather than a 2 and a 4 or a 3 and a 6 or a 6 and an 8 or a 4 and an 8 or any combination that people were contemplating. And gee, we had everybody argue all of those to us because it made their point just a fraction easier. 4. The nice thing about 4 is it's still close, but doesn't even meet properly our patient expectations. Our patients expect more of us. Our patients don't expect to be admitted in 8 hours or 6, or go home after 6 or 4. Our patients actually told us over and over again, and Kate was in the room, they said our reasonable expectation is 2 to 3 hours. That's long enough. I can get to Perth in that time. It's quite long. But you do need to have some sort of collaborative, clinician-led, data-driven, patient-focused, service redesign methodology to base it on. And that's how we designed a 4-hour program based around mainly Six Sigma principles, but we brought some lean into it as well. We also recognised early on that we actually, targets are very unpopular. Targets for target's sake. And targets, you can't get people excited about targets. The decision in Western Australia to call it the 4-hour rule was a political one, not a clinical one. We had a different name. We've lived with it. It's now called the NEAT. But we actually sat around for about 4 or 5 months after the trip discussing about whether we could do the NEAT or not, or the 4-hour rule or not, and whether we should or we shouldn't, and how we would approach it. Interestingly, I won't mention them by name, but 2 other states in Australia the same year, early and middle of 2008, did the same jurisdictional review hosted by King's Fund that we did. They came back and decided they weren't going to do it. Interesting. We came back and we decided we didn't have any choice but to do it. It would be unconscionable to know what we knew and not do something. Especially as Peter Sprivelis, a mate of mine, had published and said that the excess mortality in our hospitals associated with ED overcrowding and increased hospital occupancy and delays to definitive care were causing as many deaths as the Western Australian road toll.